Tap dance.
Yes.
Great, good morning. I'm Lee Fleischer. I'm the Chief Medical Officer from the Centers for Medicare and Medicaid Services and the Director of the Center for Clinical Standard and Quality and Professor Emeritus at the University of Pennsylvania. And I am not going to be the first speaker. I'm actually going to be the last speaker, so you can take down my slides. It's just really a privilege to begin the meeting today with really the current landscape of the nation's laboratory systems for public health emergency preparedness and response. And we're really quite fortunate today in that we have an excellent panel in which we'll be giving a number of presentations and then really go into a facilitated discussion and hopefully get additional questions from the audience. So we have Andrew Scott, Senior Radiological Nuclear Health Advisor for the U.S. Department of Homeland Security, Susan Van Meter, President of the American Clinical Laboratory Association, Scott Becker, the CEO of the Association of Public Health Laboratories, Anita Patel, Vice President of Pharmacy Services Development at Walgreens, and virtually Tim Stenzel, my partner during much of the public health emergency, along with actually Ren Salerno, who's in the audience, from a federal level, in which we had, I think, weekly meetings at least, try to assure that we could have a robust laboratory response during the COVID public health emergency. And he's director of the Office of In Vitro Diagnostics at the U.S. Food and Drug Administration. So with that, I'll turn it over to Andrew to start us off.
Great, thanks, Lee. I see my slides are up, so that's great. So I have a very impressive title that has nothing to do with laboratories. However, I am the program manager for the Integrated Consortium of Laboratory Networks. We have a federal staff of one, that's me. So we are a little bit resource constrained, so I should say that up front. This is about saying what we have now, this session. So this is what we have now. There are opportunities for growth, there are gaps. That's what we hope to get out of this meeting. I'm very excited for the proceedings to come out because that will help me move my program forward and hopefully start to encompass some of the gaps or address some of the gaps that we identify here in the next couple of days. So thank you for this opportunity, really very much appreciated. I think I also represent the federal government on the panel. So we have a balanced panel of different folks from academia and commercial labs and other sorts of laboratory stakeholders. So I look forward to the session as well. So next slide, please. Oh, I do have an advanced thing. See if it works. Okay. So foundationally, this is our mission, and we're established in the Food Safety Modernization Act of 2011. That's our establishing legislation. You'll notice that it says food safety, so you think FDA and USDA, but we also cover clinical labs, veterinary clinical labs, environmental labs, and that sort of thing, as you'll see in a moment. And then we also have a high-level executive-signed memorandum of understanding. These are our partner federal agencies. We actually have 7 laboratory networks, but 9 partners. Some of those partners are there for presence. We have participation from the FBI. We're established to address CBRN incidents, essentially, and pick up extra, leverage extra capability and capacity across the federal laboratory networks. So FBI is involved from the standpoint of possible criminal activity. And we have the Department of State as well. I just want to point that out. So here's the acronym SOUP spelled out for you. I mentioned AG already. Department of Defense, critical partner. And we'll hear from them later on this afternoon. We have the Department of Energy, represented by the NNSA. Health and Human Services, so the CDC labs contribute. Homeland Security, we're the executive agent and kind of the coordinator. Department of Interior and Commerce, Department of Justice, FBI, Department of State. and EPA, of course. Here's our structure. We have the Joint Leadership Council kind of gives us executive strategic direction, and then we have a network coordinating group that really does the work of the ICLM. We meet monthly and discuss laboratory issues and move laboratory issues forward across the federal landscape to the extent that we can. We also, over to the right, you see the subgroups and work groups, our most active of which are the methods and detection technology, the interlaboratory comparability and quality assurance subgroup, and the Rad Lab subgroup. You see our stakeholders that don't necessarily represent a laboratory network, and then our 7 laboratory networks are spelled out there for you as well. All very important partners. What you'll note there is that we cover a lot of ground. As I mentioned, we cover human clinical, animal health, plants, environment, et cetera. And it's a point to make that the DLN actually covers all of those things in and of itself as well, and animal clinical, the vet learn as well. So those seven laboratory networks make up federal labs, but a lot of their network members are state and county public health labs, encompassing some 450, I don't know the exact number off the top of my head, labs under those networks. And then about 5% overlap. So there's a few labs that are members of multiple networks. Okay, I don't know where to point this thing. There it goes, okay. So here are the network names kind of spelled out and which, what focus is of the individual laboratory networks. Kind of went over them briefly already, so I'll let you peruse those for a moment. But it's interesting to note with regard to the food supply that the USDA kind of covers animals in the field, crops in the field. Once it enters food production, it's covered by the FDA. Our tools, we've set up a set of tools for use by the various networks. Our principal one is the portal. So we have an online presence which allows communications and collaborations. In fact, we use that for communications during emergencies as well as communications for day-to-day issues if things come up. We're able to send out a shotgun email to all the members as important things crop up. We're also, our monthly meetings are hosted in that space as well. Currently, it's just a lockdown space. We have a public-facing page as well as a lockdown space for the laboratory communications and collaboration. The portal also hosts these other items. So the data exchange utility is one of the significant elements of it. It allows us to basically ingest data from the 7 member networks and aggregate it, and then allow those member networks that are involved in a particular issue to download that aggregated data to perform further analysis, information production, and then assist with decision-making in an incident. The combined registry, basically a large database. The significant part of that is methods. We get a risk assessment every other year about threat agents, and we make sure we match those threat agents against methods so that we have those available in the event. And also we have, administrative processes and procedures in place so that we can bring some organization to the chaos, as it were. Here's a snapshot of our portal. On the left, you see the public-facing portal. And as a matter of fact, this presentation's on the public-facing portal. And we also produce a newsletter once a quarter that everybody can access. And I'm also kind of excited to say that our Rad Lab subgroup is putting together a Rad Lab hub, which is a repository of resources for radiological laboratories. As you may realize, that expertise is sparse, so that we don't want to lose that institutional knowledge. So we're establishing a repository of it that others can access, and that will be public-facing as well. And then on the right, there's a snapshot of the inside of the portal and some of our tools that we use in an incident. So, and there's a process by which if an incident occurs, there'll be a principal network that's responsible for that type of incident. And if they get overwhelmed or they feel like they're going to get overwhelmed, they would activate the ICLN and say, okay, I know there's going to be a lot of samples coming in. I don't think our network can handle it. Let's spin up capacity to address that for us. It gives us tools for other types of collaboration too in an incident and communications in a kind of not classified space, but a confined space where the federal networks can interact. This is one of the principal tools, our data exchange utility. As I said, generally, we're looking for data to get ingested. One of the challenges, as you know, as many of you are affiliated or associated with laboratories, is that the laboratory information management systems are not all the same. As a matter of fact, I would argue that maybe everyone is different. So all the data fields and the units assigned or assigned to those data fields are usually very different, although most contain very similar information. So we got together and said, what are those minimum data elements that we would need to share amongst ourselves, those critical elements of information? And then we matched them against each network's method of reporting. And we actually leveraged this and practiced it very recently and found that even after all that coordination, we couldn't get a clean upload from several of our members. We fixed it. It happened. We got an aggregated data set, took some extra effort, but what we're working on now is a more dynamic process where if it doesn't get ingested, the problem columns are identified, and then the network coordinator can match those columns with the minimum data element set, and that will be saved for future data uploads so that we can ingest data more quickly. We have our combined registry. Again, a database. It's not really just methods, it's points of contact. It allows there's a search function, there's references in there as well. Kind of our operational steps, our process. So we would activate, and again, I want to emphasize that this is kind of a break glass in an emergency capability. We don't operate day-to-day typically, although we do have some degree of communication on a day-to-day basis as needed. But mostly it's in an emergency, this capability would be activated. So there would be a lead network. They would activate. They would put in an initial situation report about what's going on and what kind of resources they might need help with. There would be a coordination teleconference with all the players, all the networks that were called upon. And then it also allows further communications as the incident proceeds along the way. And then finally, there's some closeout stuff that we would do. Close down the incident. We would do an AAR. One of the significant components here as well is our information, our data sharing agreement we would establish up front about what data would be shared and what that data is to be used for. And that would be a function of the lead network. So we do host exercises. We do a monthly portal exercise to keep our members familiar with the operation of the portal, because as you know, things that you don't use frequently kind of fall by the wayside a little bit. So we try to keep members engaged on the portal and how it works. So we pick different elements to exercise each month. We do tabletop exercises, typically one a year. Sometimes, depending on how it plays out, there could be 2 per year. The next step is a confidence building competency test, which would be a larger scale exercise that would allow us, we would actually produce, distribute samples, try to engage as much of the networks, as much of the network scope as possible, and exercise the entire system. And then one step that we haven't really gotten engaged fully in yet is the interagency exercises. As you may know, we the nation hosts a high-level exercise every year or sometimes every other year. So there's a big nationwide exercise. We haven't really gotten integrated into that process. And as you know, in an event, the data is critical. And the large share of the data, at least the analytical data, is going to come from labs. So we haven't really gotten integrated into the exercise process. And what that does is I think it builds false expectations of decision makers, because kind of in exercises, it's magic that the data just appears and they don't have an appreciation for the level of effort or the timelines that are going to be associated with data production. And further, raw data from a lab typically isn't very useful for decision makers. It has to be analyzed and converted into information for them to use to make those sorts of decisions. So we're really trying to get after that particular issue. Here you see our objectives, kind of generalized objectives for every exercise, and then we have specific objectives depending on what type of exercise it is. And here you see the kind of breakdown of our exercises. The last year is not on here. We ran a bio-rad exercise. So we ran a biological agent in conjunction with a radiological agent. And as Asha pointed out, we think there may be instances where an adversary might leverage that kind of dual agent thing to slow down our response or exacerbate the problems that we might have dealing with it. One of the things we did identify is that we don't have a good list of all the all hazards receipt facilities at the labs. So a biolab is very hesitant to take a sample that may be contaminated with radiological material, not only from a safety standpoint, but from a standpoint of contamination for their labs, their instruments, and the waste stream as well. On the biological side, actually, it's a little simpler for a rad lab to take a sample that may be contaminated with a biological agent, because inactivation of that agent is a little bit more straightforward. So the safety processes are there. So that's an important element that we actually learned from this, as well as a lot of other things that we're in the midst of doing in AAR right now. But that was a very interesting exercise. So these are other aspects of what our subgroups do. Our guidance is created, basically all of the working material, it comes out of the subgroups and is presented to the NCG, which we then adopt into the process. So these are the various things you see coming out of the subgroups, and then the CBCT exercises. We haven't run one in probably 4 years, maybe 5 years. So this is a big issue. I've set aside some money to run a large-scale exercise where we can produce a significant number of samples to distribute for labs to analyze and exercise the entire system of the ICLN itself. What I'd like to do is, in conjunction with a national level exercise, do that as well. So we'd have the whole thing from soup to nuts. So current status, it's interesting. The ICLN was established as a research project, as kind of a developmental project back in 2005. My office, then the Office of Health Affairs, didn't inherit it as an operational project until 2015, and I've been program manager since 2016. Interestingly enough, my office merged with the Domestic Nuclear Detection Office to form the Countering Weapons of Mass Destruction Office. That office leadership felt that the ICLN was out of scope, and so we were unfunded for a year. Those that were engaged with the ICLN recognized its importance, so we kept on meeting on an informal basis. But I had no admin support, and I had no portal because that takes money. But we kept the communications channels open, which was a good thing, because it kind of, we were unfunded before COVID hit. COVID hit during that unfunded stage. My CMO, Chief Medical Officer at that time, felt that, boy, it would be nice to have an ICLN right about now to help coordinate and communicate. So we found some money, spun it back up. Obviously some growing pains. We were a little behind the 8 ball, One thing you probably did notice, most of you know that there are many more laboratory capabilities out there that are not encompassed by the ICLN. You should also especially note that all of the federal laboratory capability is not encompassed by the ICLN. The principal response came from the CDC flu lab. They are not a member. The CDC LRNB, LRNC, and soon to be LRNR are members. So we had only peripheral membership. What we did do though is coordinate amongst the particularly veterinary labs to say, okay, we know the clinical labs are going to need this stuff, so we are not going to use and order that stuff for the time being, and allow the clinical labs to consume those supplies. What did end up happening later on in the event is that some of our veterinary labs got CLIA certified. Those of you involved with clinical labs know that CLIA certification is required to do clinical laboratory work that's going to be used for diagnosis and treatment of humans. So our veterinary labs did get certified and started processing samples. They could do screening samples, but they just couldn't do the samples for diagnosis and treatment that we needed. So there were some ways we could get involved, ICLN, but there was no initiating event because none of our members were directly involved because it was CDC flu lab, and so we didn't fully engage, unfortunately. We did do an AAR, lessons learned from our experience with COVID across the laboratory networks as a whole, though. So that has helped us as well. You see our funding is, in federal terms, relatively mild. We have grown somewhat over the past couple of years, and now I'm at the top end of that range. A lot of that money has been set, a good bit of that money has been set aside for the purposes of exercises. You see the FTEs, so we're trying to grow resources as well so that we can really increase the scope and try to encompass more of certainly the federal laboratory capability, but also grow outside of that federal community too. So our intent is to look at setting up, am I running short on time? Yeah, I think I'm running short on time. So I will finish up. We'll deal with gaps later. And I'll be followed by my colleagues that will talk about other areas of our nation's laboratory capability and capacity. Thank you very much.
Thank you so much. Appreciate that overview. And I think one of the profound statements you made is data to information. And having lived through this last 2.5, 3 years, I think that's a key question that hopefully we will address on the rest of the panel. And with that, I'll ask Susan to come and present from the perspective of ACLA.
Good morning. So it's nice to see you all. I thought I was going to be going after Scott, so I could regroup after that. But this is great. So he's going to have to forgive me for a monkeypox slide or two. So I represent the American Clinical Laboratory Association. So we are large clinical laboratories, large reference laboratories, both academic laboratories, laboratories like LabCorp and Quest, esoteric labs like Exact Sciences, Myriad, Near Genomics, and the like. All of whom have had significant experience during COVID. Some have had experience during MPOX. I've been asked to cover a really broad range of issues to kind of level set. As Andy had said, we are really just sort of setting the stage during this session and later look forward to getting into more critical observations and recommendations. So my focus is broad, again, on commercial, independent, academic laboratory systems, roles, responsibilities for these private labs and surveillance, early detection, surge, and response. So it is rather broad. So this is just a very high-level set of definitions for these different types of laboratories. And for those of you who know this very well, there's a great deal of overlap. Great, okay, thanks. There's a great deal of overlap, but a lot of commonality as well amongst the different types of laboratories that I'm going to speak to today. So certainly exceptions, certainly crossover. One of the crossover issues, for example, is sometimes you will have commercial laboratories that will be partnering very closely with hospital laboratories. Those hospital laboratories might be academic medical centers for both the day-to-day operations of the laboratories or partnerships to help ensure that patient samples are being tested rapidly and appropriately. So just a quick look at how to think about the impact of clinical laboratories in the economy. I think these kinds of data are often helpful. Here's a sense of the economic impact, number of employees, and the like across the clinical laboratories I had mentioned. And then obviously points of commonality. This is going to lean a little bit closer to commercial laboratories in this slide, but from the ordering and sample collection where there are some responsibilities, but often, as you know, clinical laboratories are going to have some distance from the patient. For large commercial laboratories, it's really important to also recognize the logistical mechanisms that are in place, very sophisticated logistical systems of transport to ensure that samples anywhere within the country can be taken to a laboratory that has capacity. And the laboratory services, very broad, as you all well know. And laboratories are using both laboratory-developed tests and then also avail themselves of use of tests that are developed by manufacturers who manufacture for the commercial marketplace, more the Hologics, Abbott, Roche, BD, et cetera. So it's a combination of those types of tests that are used. And then certainly laboratory services are encompassing assistance provided to clinicians in contemplating which tests should be ordered and guidance about how to assess those test results, which we all know are really foundational to quality decision-making for clinicians. Results reporting, that takes place as well. That's a very significant area for us during emergencies, of course. So we have found that while results reporting is a very significant priority for all clinical laboratories, there's been challenges during emergencies to make sure that clinical laboratories can actually deliver the information as rapidly as possible, but the information actually that we hold and have. There's very many instances, I know we'll talk about this in later sessions, when there are requests for laboratories to deliver any numbers of different types of information, demographic information from states, municipalities, tribes, et cetera, and we simply don't hold that information. So an area I know we'll talk about moving forward. Just quickly, oversight of laboratories, as you all know, someone mentioned CLIA earlier, Andy mentioned CLIA earlier. So CMS oversees clinical laboratory operations and to some extent tests themselves. CDC provides advice and guidance to CMS on CLIA, as you know, but during a public health emergency, when that is declared and FDA moves forward with emergency use authorizations, so then clinical laboratories will also work in collaboration with the FDA to meet those EUA criteria. A few other key issues to think about as we're setting the stage. When laboratories are contemplating what, in the case of an emergency, will determine if they will be getting involved, if they'll be developing a test, if they'll be scaling up capacity. They're going to contemplate issues like, is there a code for the test in question? Can I actually bill for that service? Will public and private payers recognize that code? What does coverage look like? Under COVID, because of congressional action, coverage was very broad for both public and private insurers. Obviously, that's going to change come May 11th with the sunset of the PHE. Payment will also be significant variable in contemplating what steps can be taken to support USG response. And payment, as noted on the slide, we're going to think about a lot of different variables that go into assessing, is the payment going to help cover the cost of the services provided? And then, of course, what are clinical guidelines, guidance, recommendation? That is, how do clinicians understand and patients understand the various use cases for tests tests. I'm sure there's a lot of experience we all shared early in the pandemic in contemplating a molecular test, an antigen test, serology tests. What are the use cases? Was information clear, et cetera? So that's going to be very important. And then also, I have to emphasize this point too. This is sort of very important underlying issue for us when we think about payment policy issues and the capacity of laboratories to make decisions about supporting U.S. government response to emergencies, big or small. Right now, there is relative instability when it comes to what is Medicare going to pay for services under the clinical laboratory fee schedule. Absent the change in the law, clinical laboratories that get paid under the CLFS face an up to 15% reduction for around 800 codes. This is after 3 years of reductions. So it's an unsustainable pathway, truly. We're looking to ensure that there's mitigation of the reduction so that there's greater predictability, because predictability in reimbursement, again, is going to be a critical factor for laboratories in determining decisions for moving forward in response to any emergency. When we think about surveillance, early detection, and surge response, I want to recognize our colleagues at the CDC who are here today too. An important part of how we think about collaboration in this area is spelled out in an MOU that was put in place not too long ago. You can see highlighted in yellow some of the entities, including our colleagues from APHL who are here today, are part of this collaboration, this MOU. These types of conversations can be enormously helpful, and I want to underscore that the importance of public-private partnership, both before any potential emergency and during it, really can't be emphasized enough. At the bottom of this slide, you'll see I've noted just a few of the departments or agencies or entities within the U.S. government. I even left some off. I was thinking this morning as I was driving here, I can't believe I didn't add BARDA. I can't believe I didn't add NIH RADx, but it's, all of these entities have been tremendously important. And I think the big takeaway here from this slide is that it can be enormously challenging for the clinical laboratory community to understand the role and responsibility of each of these entities, how to engage and interact, how they engage and interact with each other, how coordinated they truly are, something I think that we'll probably reflect on moving forward. And I thought that I would wrap up remarks by just giving you a quick snapshot overview. You all know this so well, but I think it's good to just reflect briefly. Role of clinical laboratories in COVID-19 and MPOX. So this is one of my all-time favorite charts. I know it's a lot to take in, but let me just explain what this is. And the dark blue represents from the beginning of the pandemic, roughly March 2020, what were shipments from large manufacturers of molecular COVID test to clinical laboratories. So that includes commercial laboratories, independent laboratories, hospital laboratories. A lot of these really are run on high throughput instruments. Some of the shipments also reflect extraction reagent, other reagents, et cetera, that were used in the development of LDTs. So this is imperfect, just like all COVID data are. But it gives you a sense, and it's not 100% of manufacturers, but it's pretty darn close. And the purple dots show the number of molecular tests run. That's based on public data, state-level data, again, kind of dirty data, but it gives us at least a directional sense. And what's important here is this, again, is molecular laboratory testing. And look at the massive ramp up that we had. Our members were roughly half of testing in the earliest stages of the pandemic, right? We think about commercial labs that have the great capacity to really surge in testing, right? But once manufacturers came in with tests that can be run on high throughput instrumentation, you see those numbers go up significantly. Over to the right, you can see Delta, and then you can see Omicron, right? The point here again is intensive public-private collaboration. This is the laboratory response, broadly speaking. So this is important to reflect on. And let me just one quick slide here on or two on MPOX. and what I want to emphasize here too, much less volume, right, than COVID, obviously. But what was the important characteristic here? And there are folks that are on the panel, and Dr. Fleischer, who is moderating today, who've been like heavily involved in this. But the collaboration we had with our public health laboratory colleagues, government entities, was really important when it came to determining how to really augment capacity for Mpox testing. So several ACLA members, commercial laboratories, some are in the room today, agreed to develop LDTs and take receipt of the CDC 510K assay, and really significantly ramped up testing capacity rather quickly. So, a bottom line here too, again, it's public-private partnership, right? That's really essential. The more we can do to contemplate how to ensure in times of emergency and times of non-emergency, we have clear lines of communication, strong collaboration. So I know I'm not supposed to get into recommendations, but just a few issues of consideration. So things to think about that have already been mentioned: data sharing, access to samples for test development, agreements among test developers and around development of tests, laboratory capacity, thinking about what a market looks like. If we're thinking about H5 today, there certainly should be H5 assays available. If we've had fewer than 10 cases globally since January 2022, that's going to take a particular type of thinking and policy to make sure that assays are available, because there is very little market, obviously. So we'll get into some of the other issues too, but stockpiling, vendor managed inventory. You can't talk about clinical laboratories these days without noting the workforce challenges that we are all facing. Cytologists, for example, I mean, really across the board, that's very important to think about moving forward. And then finally, just a few other issues. Always, we're going to think about what is the clarity on the regulatory landscape. We happen to think there might be some additional authorities that are needed to help provide that clarity and make sure that we can all move as swiftly as possible in the event of an emergency. And then, of course, the importance of coding, coverage, payment, and the predictability that can provide, and then the clinical guidance piece too. So hopefully that whirlwind tour gives us a little bit of food for thought and thinking about what the current landscape is, and I appreciate the opportunity to be here today. Thanks.
Thanks so much, and I look forward to your further comments on the regulatory landscape. And now, given my mistake on the order, but we will now have Scott present his perspective from the Public Health Laboratory.
Thanks very much. I appreciate it. I'm from the Association of Public Health Laboratories. We're glad to be here and participate in this, and it's great to be in person to see some colleagues who have become friends. I actually, before I begin, I want to comment on Susan's last slide. I could have used that exact last slide. So that's just saying our system has these considerations no matter where we sit. And I think that just also proves the point that being on calls probably twice a week is mind melded a little bit. So I'm going to talk about the roles and responsibilities of the U.S. public health lab system. And I'm coming at this from this post-pandemic perspective. So the U.S. public health laboratory system is complex. In every state, territory, DC has a central public health laboratory that performs laboratory services for their jurisdiction, for their population. Many states also have local public health laboratories. They tend to be smaller, but they range in size from very large city labs like New York City, LA County, et cetera, to very small facilities that may serve a region or a community. Some public health laboratories, and we use that term rather broadly, specialize in one area of practice. Some may provide services for environmental health, food safety, and as well as agriculture, and that was mentioned earlier, the veterinary sector. And these specific facilities may not be titled public health laboratory, but that's the function that they serve. And our member laboratories ascribe to a culture of quality. They strive to improve operations both at their facilities, but also in the clinical laboratories within their jurisdiction. So they do that by serving as a nexus of communication, coordination. Oftentimes we'll get information from the CDC, move that on to the clinical laboratory sector in the community. And in some states, not many, but some states, the public health laboratory or the health agency regulates clinical laboratories in their jurisdictions. Some public health laboratories also conduct applied research and as well as perform complex testing. So all told, there's a few hundred public health laboratories in the U.S. Again, every state has a high complexity public health laboratory. And again, the smaller ones are there for other support. So here's the 11 core functions of public health laboratories. And this is something that CDC and APHL came together decades ago now. And I just want you to take a look at some of the core functions and think about it in context of this meeting. There's disease prevention, control, surveillance. There's the outbreaks that we're involved in, the specialized testing, reference testing, the data management that's so critical to ensuring that the answers, the results get to the right place, emergency response. Absolutely critical. Chemical exposures on the environmental health side, and then partnership communication, training, education, and yes, even policy development. So these really are the core functions. I want to point out some of the specialized testing, for example, newborn screening. In the U.S., 97% of America's newborns are tested in public health laboratories within their first days of life. That's a critical service. That was something that was challenged during the pandemic. And to Susan's point about the supply, and I will make some comments also about what's needed at the end, but the notion of what are essential diagnostic services needs to be considered. And newborn screening happens to be one of those. I think it's important to take a look at, public health laboratories are clinical laboratories or they're environmental laboratories, but we'll focus on the clinical lab aspects that they perform. It isn't so much the what they do, it's the why they do it and who they provide their services for. So the public health lab serves the population within its jurisdiction. Private laboratory services focus on the needs of the individual patient. Both of these systems conduct testing, but again, it's the who do they serve, why do they test, that I think are the key components. Public health labs also tend to do testing for the underinsured or the uninsured, and we certainly saw that during both COVID and monkeypox. So the two parallel networks, and I'm going to call them parallel in this setting, one public, one private, interact closely in peacetime, and they also interact extensively during wartime, especially in the reference testing arena. In times of public health emergency, the interaction of those systems becomes very close, and that connectivity is vital to providing those services that are needed to determine the extent of the outbreak. The data is used by public health agencies to drive public health action to limit the spread of the pathogen. But I think there are times we have to think about which of the networks are involved when, and typically the public health sector is involved at the very outset in terms of that early initial detection before it moves into other sectors. And so what is this expected role for public health labs in an outbreak? So the most important role is in those early stages, the initial threat detection, followed by, in some cases, assay development, and then broad testing until other laboratories come online. Traditionally, public health labs have not been terribly well funded, nor equipped to sustain high throughput testing for long periods of time, though of course many of them did this during COVID-19, and I suspect that they may fulfill that role to some extent in the future, never to the extent of commercial and larger clinical labs. So I want to focus a little bit on what was accomplished during the pandemic, what we went through. So, of course, testing during the initial stage, that is, and I have to say this, once a test was available, that actually worked. And that was a 3-week delay. we had a long-term sustained, and it did end up being high throughput. So, of course, not to the capacity that commercial labs have, but many public health labs were able to procure high throughput instruments that are now sitting there potentially waiting for what's next. So we have to really think about what is that warm base and what do we do in peacetime? Because one of the concepts I want to leave you with is that it is the job of public health laboratories to flip from wartime to peacetime back to, from peacetime to wartime back to peacetime. We do that often. We do that often without people knowing about it. So in terms of readiness, that's something that we are working on all the time based on whatever the threats are. And Asha talked about the various pandemics that are actually out there. There's other threats that are happening around the world that public health laboratories are getting ready for right now. Also, genomic sequencing to detect variants. We built up our network very, very quickly across the country for genomic surveillance. And then, again, wastewater is another area that also has been built up. The National SARS-CoV-2 Strain Surveillance, the NS3 program, formed the basis of that genomic surveillance in the US, and of course it's gotten expanded. So ultimately, there were about 150 laboratories, public health laboratories in our membership that were testing for COVID at the state and local levels, including, as I mentioned, some veterinary diagnostic labs and others from other sectors within government. And that should say by now 27.5 million specimens were tested. In the overall scheme, given what happened in the country, it now looks like a low number. It certainly didn't feel like a low number. So I want to focus a little bit on the LRN, and this was mentioned earlier. So there's two different LRNs. There's the LRNB for biologic, LRNC for chemical, and I'll address those. So first, to talk about B. The LRN as a network was established in 1999 by APHL, CDC, and the FBI as a network of labs that could prepare for and respond to bioterrorism. So bio was the first use case, if you will. So today's LRN has the two components, B and C. There are currently 129 LRN-B labs across the country. You can see them here. And there is an LRN lab within 100 miles of 90% of America's population. The LRN and its partners maintain an integrated national and international network of labs that are equipped to respond quickly to acts of biological, chemical threats, emerging infectious diseases, and other public health threats and emergencies. So you also heard a little bit about radiologic, right? There is no LRN-R for testing. I want this to sink in. Given what's going on politically, given what's going on in terms of national and global security, we do not have this capacity in the country, and I think that's a huge vulnerability. That's all I'll say on that. But it is a gap in the readiness. So back to the network. It is a diverse network, so it covers federal laboratories, so again, LRN, federal laboratories, state and local laboratories, military labs, food testing, environmental vet, and there are some international laboratories that also are part of the LRN network. Now, what forms the basis? You got to figure out where specimens are going to come from. That comes from hospitals, clinical labs, other places. We don't just invent these specimens. They actually come from the community, and they go into this system, typically. So the network provides these kinds of things. So the LRN is a CDC program. Congress appropriates money each year to CDC, and then through the FEP cooperative agreement, funding goes down to state and local LRN member laboratories, and this funds lab positions, reagents, sometimes renovation, and sometimes when funding is available, and that is not very often, there's funds for instrument refresh, so looking for latest technology. Individual states are responsible for determining how the funds are going to be divided up within their state and within their other laboratories. So the example I use is California has the largest network of local public health laboratories. I believe they have 10 LRN laboratories that are at the county and city level, as well as the central laboratory in Richmond, California. LRNB uses a now familiar tiered structure again, with thousands of private clinical labs that serve as sentinels, ruling out and referring to the reference labs, which are the LRN labs. And these reference labs detect and characterize the biological threats, such as anthrax, monkeypox, mpox, and other things. The higher level characterization is really done at the federal level, at the federal laboratories. So this slide illustrates the LRNB's role in the mpox outbreak, and that began when an LRNB reference lab at the Massachusetts State Laboratory first detected the virus. The LRNB network, I should note, was never activated during COVID-19, and for the reasons which we do not understand. But looking back on mpox, this made us acutely aware of a vulnerability that must be addressed. A real-time PCR assay developed by the CDC was available and it worked. FDA approved and distributed this to the LRN laboratory network. CDC did as well, of course. The test had been developed years ago to allow differentiation between mpox from the use of smallpox virus as a biologic weapon. The test was based on manual extraction, and it had not been adapted to high throughput. That was a big challenge, not just for us, but also for the commercial labs that ultimately agreed to perform this high volume testing that was needed, and many of whom adapted the CDC test. But that took time to ensure that it could be used on high throughput instruments, et cetera. So the LRNB and the recent readiness for introduction of the Ebola virus should also be noted. A test for Ebola Sudan species was available on the BioFire FilmArray Warrior panel, and multiple LRNB reference laboratories were ready to test. This was not a test that other laboratories were excited to take on. So I think you have to, to me, I could also have titled this the case of three different experiences. So our experience in COVID was everyone got up and running. The experience with mpox is public health labs got up and running, commercial labs came on for the, for that capacity need, if needed, right? And then Ebola, now Marburg, this is all public health, right? So I think when you think about the roles, we also have to think about what are the levers and what are the opportunities that we have to stand up this system. Susan and I have a gentle disagreement at times over the concept of system. We look at it as a system of systems. There are systems, but then there's this overarching ability to come together and figure out how do we, as others have said, move forward. So I'm really close. So here are some of the essential needs that we think in our community that are necessary to move forward. So we need inactivation procedures, up front. We need more automated extraction so that we are not left with the slowest test possible out of the gate. High throughput. Now public health labs have high throughput instruments. Threat agnostic sequencing. That's something that needs to also be moved forward, and look at what the network model really looks like for surge. So we didn't need the capacity we ultimately gained in mpox. We might have, we didn't need it. We didn't have it initially in the public health lab system in certain locations. We had it across the LRN. We just had no mechanism to move specimens, data, that sort of thing. So LRNC is a different animal for chemical testing. There are 3 different levels. I think the important thing to recognize is that level 1 labs are the most sophisticated. They are going to be the surge labs for CDC. Level 2 labs have the broad array of competencies and capabilities. Level 3 are package and ship. So you can see here there's 54 LRNC laboratory members. So here's where I look at what the sector roles and responsibilities are. This is not a perfect diagram. I would like it to have greater porosity between and amongst the stages. This looks too stepwise. I think there's a lot of flow in between and flexibility. But if you just take a look at, we could look at mpox, right? So test was available at CDC, deployed to public health labs. It was actually pre-deployed to public health labs. That was a good thing. and you had the regulatory system right there at the ready. That was great. Financing, not so sure about that, right? So we have to think about those things. And then where does it go? Well, in this case, it moved also to add on to the commercial sector, right? So five laboratories that agreed to whatever the terms were with CDC. We did not have hospital labs involved in that. Okay, so I think there's pros and cons, but we have to just think about, when I think about the system and I think about these different areas, then stage 4 could be urgent care, primary care, and then certainly over the counter, and that's definitely an area that we're going. But let's not forget the supply chain. That's a huge bottleneck for every part of this sector. So I want to leave you with one last thought, which is this: to reimagine the laboratory system. It's about all of us. It's about the entire sector getting up and running. But we don't have a playbook for this. We do not have a playbook for this. When do you turn on certain things? We need readiness. We need administrative readiness, all sorts of things. But that's the critical point that I believe. We need a structure within government. So I'm not going to be able to be here the rest of the time. So I'm going to use this moment to address what Asha said, which is, what do we need as a concrete recommendation? I believe that we need a structure within government that brings all of this together on a permanent basis. So we don't have to reinvent this. The diagnostic playbook can help us as a decision tool, but this needs to live somewhere. It's way too important for our population. Thank you very much.
Thank you. Thank you. Anita, from the perspective of Walgreens.
Good morning. So it's very exciting to be here, and thank you all for having me. I realized really quickly my goal for the day is to put pharmacies in stage 4 on Scott's slide. So that's the goal here. So I was invited here to talk through pharmacies and how we represented an entire new network that was created through the COVID response. I obviously have a Walgreens hat on, and we'll take this from a Walgreens lens. Just full disclosure, I see some familiar faces, but for those that I don't know, my name is Anita Patel. I'm currently with Walgreens, but spent the last 18 years of my career at CDC in public health preparedness and response. So this new platform in understanding where these connections are between public and private sector are extremely close to my heart. And being as a part of the federal response on the COVID efforts really shone a light on how we can do this better, and the time is absolutely now. I'm going to start first by backing us up on why we even entertain the idea of pharmacies for the COVID response. This was a time and a period where the nation was scared, as you all know. We had challenges standing up laboratory capacity, and we had to be able to test in order to be able to arm people with the next best actions. I think another major consideration for this was we had no medical countermeasures, no vaccines, no therapeutics. Testing and infection control practices were the major factor that we had, major lever that we could use for mitigation. But we were at a point where we couldn't actually rapidly scale nationwide testing, lack of data and information. I'm going to build on what my colleagues have said. It's not just data for info, but data for action, and sustainability and trusted sources became so super critical at this particular time. The other major challenge, as many of you know, is how disproportionately impacted communities were for COVID. So although we had this large scale need, there needed to be a focused effort and energy to be able to reach within communities to make sure that those that were most disproportionately impacted knew where they could go to get testing, to be able to, again, take the next best action. So some of the decisions that were made almost 3 years ago today, there was really focused on setting up a better, more rapid public health response infrastructure with private sector. With all of the work that the public, that CDC had done with pharmacies throughout the years, starting back in 2009 in the H1N1 response, it became really common knowledge that pharmacies would be leveraged for medical countermeasure delivery and distribution, and to be able to consult patients like we did in Zika if additional resources were needed. But this was a different type of response where we had to be able to scale to test. Testing was not widespread at this time, but the trust with the partnership that was already there was in place, allowing this new capability to be built out. So through ICAT, the increasing community access to testing program run by CDC, we were able to scale testing sites to over 30,000 sites nationwide. Over 7,000 of those happen to be a Walgreens location. This didn't happen accidentally. There were deliberate efforts that were taken, and just thanks to all of the federal colleagues that were involved in making this come to life, there was an effort that actually took a step back to say, what do you actually need to mobilize? Because this was a new space, and we knew we had these community level locations that, by the way, were open, we knew that we had to be able to lean into them. So what actions, what policies, what regulations, what fiscal considerations needed to be in play in order to mobilize this whole new network? So looking at scope of practice became super critical. Could a pharmacist order a test? Could a technician order a test? Could they result that test? Could they actually have those conversations with patients to do the next best thing? In terms of license reciprocity, we were in a point where we had shortages within the healthcare infrastructure. We needed to be able to go across state lines and make sure that we had those capacities built in. Cost not being a barrier to access was top of mind for everyone. So how do we take the steps and the measures that were mentioned earlier, make sure we've got the right things for our systems to work? So this is tactical coding. Everything will break down. That infrastructure has to be in place in order for this to be smooth. Zero cost sharing was also something we needed in place to ensure that people came, and those barriers to access, the social determinants of health, are all tied to this is a major component of that, of course. And then non-contracted billing. So this is another major factor. The way our infrastructure works, for pharmacies to be able to mobilize, you actually have to have a payer contract for that particular service. This is hundreds of payers that we're talking about that go step by step to have these negotiations with us. Like, that is just our current infrastructure. The ability to bill a non-contract provider became super critical for implementation. So all of these were considered. They were all part of either the public health emergency declarations, or they were part of the PrEP Act in order to mobilize the system. So super deliberate efforts to step back to say, what is it that you need to operationalize? So for Walgreens, this became a critical piece of our fabric. We are in communities all across the United States. I think many people have heard the stat that 95% of the population lives within a 5 mile, over 90% of the population lives within a 5 mile radius of a pharmacy. 88% of individuals live within a 5 mile radius of a Walgreens who are Black and Latina. 50% of Walgreens sites sits within underserved areas. So now this becomes a lever to pull for public health to get into communities in a more efficient, targeted way. As we thought through scaling, of course, a lot of this happened to be tied to supply. It also was the policies and the regulations coming to life in a quick way. We were able to scale. We're currently in over 7,200 locations nationwide for COVID testing and over 5,500 locations coupling flu and COVID together. For the 35 million tests that have been conducted to date, 50% of all of those sites are within an underserved community. So the other major component to our infrastructure, and I think this is a huge asset for public health, is that we're able to adjust the system down to the community local level. Prioritizing sites, whether that was because of infection control practices, requirements for drive-through, or COVID disease rates, for strategically placing sites around airports, especially when some of the travel guidance shifted, ensuring testing sites were available across all states, and also looking into rural communities. The distance of stores with and without a test was within our control, so we were able to adjust that in communities where we knew we needed more capacity. Testing locations were also optimized when the school guidance changed, because now all of a sudden the communities needed more testing. And then testing equity, of course, from social vulnerability, and looking at medically underserved communities was definitely part of our overall rubric. Data. So we did talk about this some. This is huge. This is exciting for me coming from CDC and the challenges of data, especially pre-COVID. This is a data beast. There's so much data in the healthcare system. To be able to have access to this data, analyze this data, and glean the insights needed for action with this data ends up being critical. With over 7,000 sites nationwide, daily information feeds coming through, it's a data pool that can then be triggered and shared for information purposes. It also starts allowing us to see more tactically, who are we screening, who are we testing, and what are the results of those tests and tying those together. We also happen to be doing vaccines, so you start being able to see stronger correlates of what's happening in terms of disease and medical countermeasure effectiveness. Not to belabor the laundry list of things, but this really does require a comprehensive infrastructure for implementation. So recognize that we've got an absolute need for public health laboratories and for the additional laboratories that were discussed. There's going to become a point where things have to scale within communities. So how does that scale, and do we have the foundational components of that infrastructure in place for those that are scaling? The right set of clinical expertise, the partnerships in place, whether for us it's commercial labs as well as our public health partners. This is at the state level as well. We weren't just partnering at the federal end, as well as health systems and payers. Providing the next best actions and having that trusted conversation with patients. Patients show up in a pharmacy 12 times more than they do in any other care facility. So having that interaction opportunity, those times for conversation, ends up becoming an opportunity to be able to care for somebody and getting them to their next best action. Health equity, as I mentioned, access, scale, capacity across communities. Digital experience is top of mind. The world has changed. There's a stat out there that says that COVID actually expedited the digital world by 9 years. So this is now a change in environment for what the public at scale expects to be able to do in their digital health experience. Surveillance, data analytics, genome sequencing, these are all things we're doing with our lab partners and being able to share information back to our public health partners. And reporting. So the quality of the data, the information feeds, one call and you get 7,200 sites. So this is where, when Scott talks about levers, it becomes important to know where they are so that they can be pulled when needed for the nation or down at a more community-based level. Integration within the supply chain is critical. What we tend to do, and I'll own some of this in my last career, create public health supply chains that are running parallel to the usual system. The lab response was really successful in the fact that that dovetailed in, allowing the integrated supply chain that currently exists to be leveraged. Expansion to test and treat. I want to call this one out because it's not just about testing for us, it's about the next best action. So was it infection control? Were we directing patients to another triage protocol that allowed them to know what they had to do next? Should they stay home? Should they wear a mask? All these things became critical for that individual. So even though this was population health, the individual action was a super critical component to improve overall public health. The test to treat actions that were taken and the authorities that were provided for us to be able to prescribe did start changing what we can do with the patient and increasing access overall because they're already getting tested with us, completing that overall experience. And then having dedicated teams. I can't stress this enough, sitting on both sides of the houses. The change in leadership on the federal end is always challenging for the private sector. I will say the same thing on the private sector side. So our teams are steady individuals who've been there, who are part of the system, and this is their role because that information, that historic knowledge ends up becoming so critical, especially when we're in a response for over 3 years. So there's an alignment here that's happening, and I want to flag this because this is probably the one moment in time where we've got the entire nation doing public health. The other piece that's happened is we've got the mission of some organizations shifting to be more aligned with public health. So from this infrastructure being in place, the foundation of the ICAP program, what do you do next with that in order to have a warm base, as Scott described, in place so that when something does happen next time, The players know each other. I think anyone who's been in response knows that it's that saying of don't exchange business cards at the time of an event. That knowing what the capacity is, knowing how to tap into it, knowing how to pull it down. Again, one phone call, 7,200 sites across nation capacity. So the other piece just to flag is when pharmacies are multi-jurisdictional providers, action at the federal end makes it easier to operationalize everything that's in flight. So state by state laws are great. We're seeing major change within the states, but we still have 12 states where an individual can get a test, do their diagnosis, but a pharmacist can't order that test. So having the laws actually advance to current infrastructure needs is going to be a critical component of all of this as well. So I'll leave you with this last thought. It's aligned with everyone else, is what are we going to do next? So we've got this infrastructure in place. We've got the PHE that's sunsetting. With it, some of this capacity does go away. If you take the PHE plus the PrEP Act, it's over 65% of the current capacity that's in flight at just our locations, not to mention the other ICAP partners, that goes away. So really thinking through at this time, what is it that we want to do next with the levers and the foundations that have been created post-COVID? Thank you all for your time.
Thanks so much. Do we have Tim available remotely? Great. So next we have Tim Stenzel from FDA.
Hello, just doing a sound check. Hopefully, Lee, you can hear me.
We can.
I'm going to attempt to present my slides, which I will share later. And I hope you can see my first slide. Doesn't look like it's on your screen.
Yes, we can now.
Okay, great. All right, well, it's a pleasure to be a part of this event, and many thanks for the invitation. Agree with some of the previous speakers that it really is, needs to involve all of us in currently and in the future. I'm going to be covering both the current situation, but with a little bit, if not more than a little bit, of a look to the future about lessons learned and perhaps ways to do this even better. Move to my next slide. So this is a slide up to date as of today of the number of authorized EUA tests for COVID-19. We have started to see some tests be removed from the market because they just don't have a demand. So there are a lot of tests that are EUA authorized. One might ask, do you need this many different tests? And I think it's a good question to ask. Rather, might we need fewer tests that are well validated, produced in high volume, able to be used by most laboratories, and automated as much as possible? And to get that as fast as possible, might we want to have agreements in place with manufacturers to be able to not take the time to have to do contracting and things like that. But if there's an event and we need to respond, then we can do so. And the other thing is I'm going to be focusing primarily on biological pathogen responses, but the FDA is very involved with responses to other threats. This is a snapshot, a current snapshot of all the different types of tests that are available, and you'll see immediately that these really cover the gamut from high throughput central labs all the way to point of care labs or point of care sites to now over the counter and testing in the home and other remote areas. So a tremendous amount of innovation is demonstrated here and capability as well. So I did want to talk about, you know, the FDA's roles here, responsibilities, interactions, and collaborations and contributions. So the FDA did interact early in previous emergencies, including COVID-19, and then monkeypox or mpox, and then continues to do so. We have been directly involved in helping individual laboratories, laboratory networks, as well as kit manufacturers and reagent suppliers in their development efforts and in meeting the nation's needs. Another area that is showing increasing importance is data. So in especially the point of care and over-the-counter tests, the FDA has encouraged that test developers, develop a system of reporting data. We think that was important for COVID-19, and we'll think it'll play an increasingly important role in the future. So we really want to work with all stakeholders to build this information pipeline in a highway, and there's still a lot of work to do. Another role that the FDA plays, and this is not in an exclusive, and is not an all-inclusive list, is MDR, or medical device reports. Any problems with tests, we monitor on a regular basis, both for emergency response tests as well as every other test that the FDA oversees. We have used this system for COVID-19 and for mpox, but we haven't seen any issues with mpox yet. But for COVID-19, we have seen some issues that were noted by the MDR reports or other reports that did require certain manufacturers to address concerns, and they were addressed, and we were very public about that and worked closely with test developers to communicate with their customers and keep an open line of communication open. The FDA also took on a new task for COVID-19, continues it for mpox, and has expanded to now influenza. That we've created a bioinformatics pipeline that allows us, because we have, the details of tests that have been submitted to the FDA. We know the primers and probes. We know the antibodies and the antigen tests. We know the constructs of the serology tests. And so we can use bioinformatics and in collaboration with NIH and CDC, in academic centers that we've worked with, to keep track of test performance when there's a new mutation or variant. We now have advanced to the level that if a variant arises outside the US, we don't have actual samples. We have a pretty good predictive system, both for molecular tests and antigen tests. We maintain this. NIH and FDA still meet weekly on this, and we still brief agencies in the US government on a weekly basis on this. So I have divided my talk into response phases. There's many ways to look at responses, but we clearly have seen that the needs, the requirements, the utility of tests has shifted from early phase responses to later phase responses. So early on, in the future, we'd really love to see a prepositioned pathogen and agnostic test or tests for surveillance for potential pathogens. And after a pathogen is identified that is going to be something that we need to watch for and deal with, that same test potentially could be used for diagnosis and immediately move from a surveillance type system to a diagnostic system. However, this system or systems are likely to be low throughput, though automated molecular assays. As we saw with COVID-19 and then also with Mpox, there was an immediate need for a high volume test, likely molecular. These often were not automated or were only minimally automated. And so the throughput wasn't as high as ultimately we might need. However, they could be widely distributed and widely used. The advantage of, say, real-time PCR assays is that they can be quickly developed, quickly validated, especially with the flexibility to be able to validate on completely contrived material. Don't actually need to have the sample, as we had at the beginning of the COVID-19 pandemic. And we had limited samples also for Mpox. And then capability to be manufactured in high volumes and performed on commonly available lab instrumentation. So this was the largest wave for COVID-19 and Mpox, and was incredibly important as well. Moving next, and this has been discussed by others today, that there is a need for automated high throughput tests. So when test orders really ramp up, or there's a need to test a lot, and we saw this relatively quickly for COVID-19, and there was a desire for automation for Mpox as well, that these completely automated systems are important when they are available in many labs. Now, this requirement was different for COVID-19 than Mpox. You could argue that we may not have needed this for Mpox, although we have authorized these platforms now. They did happen sometimes later than other tests were available. For COVID-19, this automation was absolutely critical. We know that laboratories have workforce issues and that automation is very clearly needed to address the need for high throughput and frequent testing with low turnaround times, and the fact that getting trained laboratory staff is challenging. The downside of one of the downsides to dramatically increase in test orders is that it can lead to shortages of key and sometimes common test reagents and supplies, such as swabs, as we saw at the beginning of COVID-19. And then we saw shortages of plastics. So the FDA has and will continue to serve as a resource to laboratories and manufacturers on what substitutions can be made. We are still monitoring this for COVID-19, although obviously it's been less critical lately. We did post and will post this information widely on the website and have other forms of communication such as IVD town halls to communicate other available supplies and reagents that can work in labs. And then the next phase that we saw with COVID-19 is likely to be very important in future widespread emergency responses is the use of point-of-care tests. And this is now available and beginning to be used for Mpox. Point-of-care tests are usually more challenging to develop and validate due to the technologies used, as well as they're not so open systems, as well as it's important to know in non-laboratory trained personnel how the test performs. Advantages are it's near patient. For antigen tests, at least, can be manufactured in extremely high volumes and very widely distributed. However, it is low throughput, but if you have a lot of sites that are doing testing, then this can play a very important impact, especially if it's linked to additional follow-on care. Finally, over-the-counter tests. So, as you saw in an earlier slide, we now have dozens of over-the-counter COVID-19 tests. This did play an important role. Decentralization, not only to point of care, but now into the home played an important role in COVID-19 responses, like to play a key or look at this kind of technology, and as we try to prepare and think about being able to respond to future emergencies, the use of pathogen tests could play a critical role. For example, in previous emergencies for influenza, tests previously manufactured for other for influenza were able to be used. The first antigen tests for COVID-19 were developed using antibodies raised to the early 2000s SARS emergency. And so there is this cross-reactivity even among SARS that you can utilize to develop pan tests. These simple to use tests can be difficult to develop, surprisingly, but to make them simple, there's a lot of work that goes in it. It needs to be very easy for anybody to use. And because we want it to be evaluated in an actual patient's hands to make sure that patients can do the test and can get the right results, the validation can be a little bit more challenging. The key advantage to these, especially antigen tests, is they can be manufactured in the highest of volumes and supply essentially our entire population down to the individual households with these tests. I've provided a reference list. I'll provide these slides later for some of this. And I want to thank you for the opportunity to present. This was only, a very focused, minimalist approach to what the FDA has done and can do. We very greatly appreciate working with all of the stakeholders and all our partners in and outside of the government. There have been very key collaborations, such as with ACLA and with APHL, CDC, CMS, NIH, DOD. And others, and we appreciate being able to contribute in the way that we have. Thank you.
Thanks so much, Tim, and greatly appreciated. And I'm going to try to go quickly on some of the regulatory issues, given they were brought up. And I really think some of the comments that were made, particularly Scott, with respect to what happened during MPOX, is we already had a standing committee between the tri-agencies actually with NIH included, of CMS, CDC, and FDA, which really, I think, allowed us to pivot quickly. So just quickly from the regulatory standpoint, since Susan did bring that up. Next, I have this clicker. Okay. As we talked about, laboratories must obtain a certificate required based upon the level of testing, complexity of testing, and the issue is it must be done if it actually is used for the diagnosis or treatment of a disease, which got quite complex during COVID in how we actually defined what a laboratory was, particularly with respect to schools or other locations. Were we diagnosing a disease and therefore it needed a CLIA certificate, or were we using it to allow people to attend school? And I think we were quite creative during the public health emergency. Some of the responses that we were able to extend during the PHE, which are not hardwired into the system, although they may be in the future, is the remote review of pathology slides and data, the expedited review of CLIA applications. Essentially, once you put the application into the state, CMS was able to say you could start actually testing immediately. The use of alternative collection devices and expired reagents, if they still had good performance characteristic. The continuous site flexibility, so the ability of laboratories that were contiguous in the hospitals or health systems that could be used. So for example, at a university, being able to use some of the other labs to do COVID testing under their CLIA certificate. the allowance of university non-CLIA COVID testing, particularly to allow students to attend class. And a lot of this was about reopening the country. And importantly, and this is one of the questions we will continue to have discussions on in the future, is the CARES Act mandated require COVID testing reporting, and what should we do in any future public health emergency, and what authorities are there either under CLIA or do we need some more statutory changes? We learned quite a bit. When I actually assumed this position from academia, I was surprised about having CLIA under the authorities of this position and some of the issues with regard to lab quality and patient safety. I hadn't read Bad Blood yet. So understanding the need and the authorities for us, which we could say, and there were some very large labs in which we had to take action, in which had all these pop-up sites and not performing the test accurately, as well as not ensuring that the right patient got the right information back, one of the key functions of CLIA. Really, these relationships, as I've talked about several times, between the tri-agencies. What would actually happen in these non-traditional labs, like the schools, the workplaces, was critical. The temporary testing and the fact that we really had no CLIA authority or regulations that required routine reporting to any state, local, or tribal authority. So as we talked about, this is really the idea is what is the authority? It's really to provide with regard to CMS, whether it's CLIA waived or CLIA itself, is to ensure lab quality, safety, and reliability, not ensuring that the test actually detects what it says it detects. That's an FDA function. And the expertise of how to use a test is really a CDC function. We're really ensuring that the test is performed correctly. One of the key things to recognize and just bring up here is we do not have 1135 public health emergency waiver authority. So many of the activities we did during the public health emergency was really related to enforcement discretion. That actually has some dangers to it as far as if you're totally having enforcement discretion for all activities, that's essentially waiving the authority. So what should we think about for future public health emergencies within the laboratory community? The other thing that was mentioned in the last couple minutes is the complexity of payment that Susan mentioned, and how do we ensure that the laboratory system can be sustainable given that complexity of payment. Medicare, clinical diagnostic tests, i.e. monkeypox for diagnosis, is covered, subject to the usual requirement. General screening, absent known exposure, is not covered. So how do we cover those who are in the population at risk if they didn't actually have an exposure? And we were quite creative, as we needed to be during the public health emergency, but what about future public health emergencies from a screening perspective? The issue of cost sharing, the CARES Act took care of that. And lastly, and I think this is something that Susan knows well since we've had these discussions, is that the ability to establish national payment rates for new clinical laboratory diagnostic tests was really done annually, so that until that time it's done at the level of the MACs. And the MACs have the authority to set those rates at different levels, which can lead to some inequities and some potential access to care issues nationally. In the commercial space, the individual and small group plans must cover 10 essential benefits, but the coverage details may vary by state and by plan. So the testing really is covered at the plan's discretion, and cost sharing is also at the plan's discretion, which again became really quite a issue as were discussing, which is why I think Scott said most of the mpox testing was done in the public health labs, although we had a great expansion to those 5 additional labs, but it's really at the plan's discretion, certainly at the beginning. And Medicaid is the most complex of all, in that it really is based under each additional state's authority. It's an option, but not a requirement, to impose cost sharing and certain flexibility. So depending on which state you lived in, the access to testing could vary greatly. So with that, quick, because I wanted to get to some of the questions, I'd actually start, and if others have questions, please feel free to come up. But we talked a lot about the system, and I know this afternoon, there's a discussion of the system, but it would be great to hear from this panel who has worked through this, what you think are the key issues that we really should be thinking about with respect to the system. I don't know who wants to start. Scott, you want to start?
Sure. So I think I mentioned it. I think of this as a system of systems, right? I think that's actually part of the problem. I've often said when we look at a public health emergency, and use mpox as the example, there are 2 strong networks. There's the Public Health Lab network, and then there's the ACLA members, and then there's everything in between, very important, but not as organized in the same sense. I think that is a challenge, and it's historically been a challenge in the laboratory community to come together on things other than perhaps payment, needs for payment, needs for workforce. That's another area. So I think we need to look at both the common challenges, and then let's look at common solutions. But the system is a system of systems, in my view.
So this is where we disagree, it's like in a friendly way, right? So I actually think I'm not malaligned with what you said, but I think the term system implies a level of functionality that we don't have right now. And that's the thing that is distressing, right? We really have to concretize permanently institutional mechanisms for public-private collaboration across all the areas. Anita mentioned, Scott mentioned, Annie mentioned, issues that Lee just brought up, I think are essential too. So that's where my frustration is with that term, but I think we're actually aligned ultimately here. But I just also want to reflect too, it was really hard to give the presentation earlier and not say, and here are the 10 things I think we need to do, but I do want to reflect on the one that Lee brought up, thinking about like, how do you make sure that you're going to get the private sector to jump in to support an effort, right? Particularly when the market's unclear, right? How do you de-risk the market? How do you create predictability so manufacturers, clinical laboratories, commercial laboratories, even hospital laboratories, can jump in? And that reimbursement, so coding, coverage, and payment all together is massively important. During NPOX, when we had a circumstance where there were delays in determining, what would that payment rate be? So labs jump in at risk. They're committed to responding, right? That's a commitment that commercial laboratories will make. That's not a requirement, but it's a commitment that they're willing to support that effort. But when you have when you have disparate payment amounts across MACs, that can disincentivize the engagement of the commercial market. With COVID, there was an action that was taken where the administrator, and I think we sort of argue about the authorities that exist with the CMS administrator, she took an administrative action to set a national rate at a level that allowed for commercial laboratories in the country to really ramp up, to have significant capacity, ultimately, right, to ensure there was really swift turnaround time as well. So I think that's got to be a priority, those dynamics, and thinking about moving forward. So,
thanks so much, and that is true. She did just say she had the authority and did it. Interestingly, also with mpox, the ability to obtain the data was really a function of the CDC laboratory and the unique aspect of the data use agreement that was part of it. But realistically, that was, if we didn't do that, we didn't have guarantee of data back to the CDC.
So, Lee, I think on that point, I think this is where we need to take this time, not very long, to really get this right. We need to look at what the minimum data is needed in an emergency and ensure that we have administrative readiness, that we have these agreements ready to go when the lever needs to be pulled, when the decisions need to be made. I think that we've had experiences starting. I'll use Zika all the way through today, and every emergency is different. So what we're dealing with now in the public health system with readiness for Ebola or Marburg is very different than what we dealt with Mpox and certainly COVID or Zika.
Great. I'm going to take a question from the audience, but I'm going to say one word for the panel to be prepared for: interoperability. Okay.
Hi, thanks so much. John Hick from Minneapolis. Thanks so much to the panel for your expertise and your comments. You know, Scott, I was struck by your distinction between patient and population, and I wonder if one of the issues that we're having with the gaps these days is that maybe that's not a distinction that's as relevant anymore. And I'll just give an example that happened 2 months ago. A patient comes into one of our Washington area airports, gets hospitalized at a hospital in Northern Virginia, suspect Marburg. There's no ability for the hospital to do a diagnostic test. There's no ability for the state to do a diagnostic test. That test winds up going to the CDC, which, because it was over the weekend, there's no result for 4.5 days. The patient dies in the meantime until the negative test result is returned. In the meantime, if that had wound up being a positive, not only is that a patient issue, but that becomes a public health emergency, because all the people on that flight and those people that were involved in the care for that patient are at risk. But even during that time, it puts caregivers at risk in ways that it puts the patient indirectly at risk for poor outcomes. So, how do we begin to rethink that distinction between patient care and population health? Thank you.
To me, that's that flip, right? That's the flip, and that's an example of where it would happen in a day, not in an experience. Yeah, I think actually the systems. So it's very challenging coming from an APHL vantage point representing public health labs, because clinical labs are not represented as institutions. There's a lot of different organizations that represent laboratory science and individuals in laboratories. So it's that coordination, I think, that's necessary. But I absolutely understand and respect that point.
Why don't we start with the interoperability, then we'll go to the audience. I'll let Andrew start and maybe go down the row.
Sure, and I just want to make one comment on the previous question too. I think part of the challenge is that we're really all optimized for day-to-day operations and workload, and it's the ramping up, it's the switching gears into addressing an emergency situation. But to get back to interoperability, I would say that I don't think we've worked very hard to this point at establishing institutionalized mechanisms for interoperability. And I think we touched on it a little bit with standardization. There has to be discussions about standardization. I brought up data, for example. If we had some standard minimum data elements that were reported consistently across the board, the aggregation that I talked about and the ability to really get into that data quickly, and then decision makers to respond to a given emergency, I think that that cycle, we would shorten that cycle significantly. So I think that's a significant element. The other piece I think we need to be cognizant of that others on the panel touched on too is the logistics landscape changes substantially in an emergency. We have our normal routes of supply, but we're all competing for the same supplies, essentially. And we saw it in COVID. We ran out of stuff, and then we were all going piecemeal to try and figure out what non-traditional ways that we could go about getting supply that were safe and that we would have confidence in the event. So I think those are two critical pieces.
So I absolutely agree on the notion of standardizing a minimal data set and really keeping in mind for laboratories, what data do we actually have? Right? Yes. We're not engaging with the patient. We're not able to fill all of the requests that we're getting from various public health entities, agencies, et cetera. We are fully committed to providing data back to patients and providers, but let's really let's commit to having a standardized data set. But then on interoperability, right? I mean, that's like the holy grail we've all been chasing for a long time. There's a lot of legacy issues, positive and negative, for laboratories never having been part of the EHR incentive payment program, the meaningful use program, which we're now calling interoperability program. Somebody here might know, but I'll always think of it as meaningful use. There's a legacy to that is a challenge. So even though maybe we're all using HL7 to communicate with providers, maybe we're not using the same version, maybe we're not interpreting it the same way, I actually think there's a need for investment, right? Federal investment for laboratories to ensure that we have those interfaces, that the systems are actually all running the same standard, we're interpreting it the same way. I think that's massively important and essential moving forward. So just a few ideas.
So I'm going to pick up on what Susan said about labs don't have access to that data because we aren't touching the patient. I can tell you that our members spent hours and hours and hours every day hunting down people to complete the form that needed to go in for the data that was necessary. That took them away from the bench. It took them away from the supply room if there was anything there. So that was a real issue. I also think that from a historical perspective, public health was left out of the work on meaningful use until rather recently. And fortunately, I think the data modernization initiative that's going on at certainly at CDC is something that's critically important. But I absolutely agree that the minimum data expectations need to be well understood. And yes, we need to get the systems to work together. APHL operates a cloud platform that actually allows some of this to happen, but obviously it's not enough.
This is Tim. Happy to join in too with this time.
Anita, do you want to go, and then I'll let
just
Tim,
a
and then
quick
we'll go to the
comment.
audience.
I think many of the main points have already been made. The one thing I challenge, it's a minimum data set plus. The reason why is every response is so different. And so that ability to flex and shift, whether it's 1, 3 fields, whatever that is. And then the other piece I'd add is actually building off of something you said, Scott, the ability to fill a form out is way hard.
Yeah.
Yes. Like this should be so easy. Yes. And it's not. So again, more digital world that we're in, how do we make this as easy as possible? If it's data that we need, make that collection as simplified as possible. It doesn't necessarily mean less elements, just make it easier to do.
Yeah.
Tim?
Yeah, thanks. Totally agree with this discussion. And we know that in the beginning, when you're trying to contain something, you might need more information ready at hand. Later on, maybe besides just the result and the test used, and perhaps patient identifiers, maybe just a patient contact is needed later on. We have used for the FDA, we have used digital enrollment studies for home users where they filled out the essential demographics for that study on a mobile app, and that was incredibly streamlined and useful, and patients loved it, and it was very useful for NIH and FDA purposes. Thanks.
I think Joe was first. Christina, thank you as a panel for all your talks. It's a great start to the meeting. I want to follow up on the minimal data set. And Andrew, I am ashamed to say I don't know a lot about the ICLN. I've got to learn. But APHL is actually working at the moment with CSTE on a minimal data set for test ordering. It was a huge problem with monkeypox that physicians got incredibly frustrated with having to fill out an enormous list. And while we understand that that's important for case reporting, for test ordering, it ought to be much simpler. So can we have what your minimal data elements are? I mean, we've got to get to consensus. It seems to me that this is something that is achievable. You know, when we're talking about the systems, and I'll talk about that tomorrow, that's a huge and complex problem that we've got to align a whole lot of aspects. But the minimum data element set ought to be doable. So can we try and do that? And could we have your set, please?
Yes, of course. So, you know, another challenging aspect of this whole discussion is that even the simple things are hard. You know, there's complexity there that I don't think, you know, until you start the discussions, you don't realize what complexity is there. So for us at the ICLN, and you're not alone in not knowing about it, I think we've probably done a less than stellar job of communicating about the existence of the ICLN. So that's not on you, don't worry about that. But now you know about it. So so with regard to our minimum data set, it's about, for us, it's about analytical data, and it covers the space that our 7 laboratory networks cover. It's a lot of elements, but not all required elements, depending on the circumstance. So we have encompassed the space from, you know, rad, nuke, biochem, and then some of the other kinds of data like the demographic data and such like in there, but we don't have to fill all that out. So depending on the incident and depending on what's going on at that time. So I would obviously be amenable to sharing that data set. What we don't do is talk about how the tests are ordered. So that's a separate piece that we really haven't discussed, because that's really not in our wheelhouse as a group of analytical labs. How they order the tests is, I don't really know anything about it. You guys probably know a little bit more about that sort of thing. But talk to me after. Yeah.
You know, the more labs that we can get their minimal data set from, the easier it goes. If we can, you know, clearly it's easy for us to work it out from the test requisition forms for the public health labs, but the more commercial labs, clinical labs that we can get what they consider their minimal data set from, the faster we can get to consensus. And clearly we need to go with the CDC as well. But we can.
I think it's a little more, it's way beyond the scope of what we can do in the next 12 minutes, because I sit on the federal oversight for the hospital data set, and we're spending way too many hours
just in
debating
the
hospital side. But we should follow something to follow up. Next question.
So I have another question and comment about the interoperability. So I'm representing a public health lab up Wadsworth Center, New York State Department of Health. And I was really glad to hear your comments, Andrew, and to see that ICLN is really being reinvigorated, because there was a lot of activity early on, 2000 to 2010 and past. So I'm glad to see you trying to highlight it. And you really can't emphasize enough that public health laboratories, we are the members of LRNB, LRNC, hopefully someday LRNR. We're for the FERN, the Food Emergency Response Network, for both FDA, USDA, for EPA. The public health labs are the ones doing most of that testing. And we have 4 different mechanisms that we have to report data to, so the data reporting is really of concern. But I guess my comment too is, do you see more integration within the actual different lab networks? Because we have seen some real siloing again now, and it would be great to hear comments about integrating those and expanding to other labs as well.
Yes, of course, really good question. So they are literally 7 independent networks. So they operate independently, and then in that emergency scenario, come together to try and collaborate and cross-level and do all the things that we need to do in those emergency situations. So I don't talk to them about how they individually run their networks per se, but what we do get into is those little aspects of interoperability, one of the significant ones of which is that data sharing piece across the networks themselves. So, I can talk to them, and we do have, I think you're familiar probably with the other portals that those networks operate. We actually operate on the same platform. We just have different instances of the portal and different sets of tools, although we share tools as well. I think part of the challenge for interoperability, frankly, is all the different players. I mean, there's so many stakeholders. One of our challenges to grow beyond the federal space is to identify those touch points that we can reach out to most effectively. Because I can't have a group meeting with every analytical lab in the United States on it. It's too much. We talked about a few kinds of labs, pathology labs. There's all sorts of other labs that we really haven't talked about that could be players in the analytical space in an emergency. And we should have an effective way, an institutionalized way to leverage that somehow. I think the problem's large, but I think it's a tractable problem, and that we can, to use a metaphor, is we can eat the elephant one bite at a time. We need to figure out what those critical pieces are, and those easy elements, those low-hanging fruit to address first, and then we need to start coming together as a community to talk more about it. And I know in emergencies, the best thing is that if we know each other and we can talk to each other on an even basis, and work together to get, to reach the end state, whatever that is.
Any quick comments? Because I want to get to a few more questions.
Hi, I'm Jeanette Warner. I happen to hold 4 CLIA licenses at Emory University in the system at Emory University, so I know a little bit about CLIA licenses. But I think one of the things that has struck me as part of being a laboratorian, and it has alluded to with the example given by the Ebola case that in Virginia, is we've instilled in laboratories this fear, in laboratory techs, this fear of handling some of these specimens as if they were like untouchable. And in some way or another, we need to realize that if we're using universal precautions, we probably don't need to, and I don't want to be saying that we need to be sloppy. We should not be sloppy, period. However, there is this complete fear of handling these specimens, and we need to look at the risk assessment, need to tell people that they're okay handling some of the specimens. The other thing that we need to make sure is, as was alluded to in this Ebola example, which is, I think, great, is that results need to be coming in a more rapid way, where we talked about, how do we send the stuff and all the things that we need to tell the state lab, we need to do this, we need to do that, and it's impossible to fill this humongous questionnaire. Yes, we fill up questionnaire, we send the specimen, and it takes, I want to say years, but it's not years, days for the result to come back. So we need to, in some way or another, be more proactive as to what needs to be done. And lastly...
Yeah, because I'd like to go on to other questions. Any comments?
Just do want to give you a little bit of hope there on that last point. So through the Data Modernization Initiative, there is a lot of work going on and more to come on electronic test order and result reporting. It's exactly for that reason. We see that as it's not a easy thing to accomplish, but it is going to be the most effective to address those kinds of things. Timeliness is really so important in any situation, especially in those examples. So I really believe that there is work going on, but we will continue to, and I don't want to say plug away. I mean, this is a huge, huge need, and a lot of work is going on thanks to work in the Division of Lab Systems at CDC and other places.
And I want to just mention to your first issue about health and safety. During our BioRad exercise, that's one of the things we identified as an issue. So we had the RAD folks make a primer, a safety primer, and the bio folks make a safety primer to exchange. So that's a good point. I'm gonna see if I can get those cleared for public release and put them on the public-facing website, because I think those would be beneficial. Thank you for that comment.
Thanks for everything the panel has done so far. Andy Pavia from the University of Utah, so I've got a foot in public health, a foot in Arup, and a foot in Intermountain, which gives me a unique perspective because they have been able, through great work by the three organizations, to link a lot of the EHR data to public health reporting. So we have a pretty good ELR system, but it required tons of back-end work on incompatible systems. So it seems that the leverage points are laboratory information systems, which need better standardization, and EHRs, which need the ability to transmit data in a appropriate fashion to public health. What do you see as the pressure points to solve that Tower of Babel problem?
Well, I'm going to ask Dr. Fleischer what he thinks, but I was just at Arup last week, and remarkable work going on in Salt Lake City there. But I mean, I think there has to this discussion, for example, all of us understanding that a lot of work needs to be done, right? And informing policymakers that this is an emergency in and of itself, right? You have to have functioning systems to be able to exchange data in a timely fashion, right? And minimize those data elements to make it most efficient. So I think there's a lot of contemplation going on at CDC, elsewhere in government, but I think it's incumbent upon us to inform policymakers writ large on the Hill, et cetera. Right now is the time where Congress is looking to reauthorize the Pandemic All Hazards Preparedness Act. They have to do that by September 30th under the law. I know ACLA is taking our recommendations to the Hill, but I think it's good if we as a broader community emphasize the need to solve this challenge. And I personally also think there needs to be federal investment to help interoperability along, but perhaps Dr. Fleischer.
Yeah, no, thank you. And there is a group at the White House who has challenged us with this question. And Mickey Tripathi's, the ONC, we have put together a small working group of FDA, CDC, and CMS. And the real question is the use cases. So this has become an important use case, and we will be bringing it to that group of how to think about that future. So, last question.
Yes, hi, I'm Don Karcher. I'm a pathologist at George Washington University, about 8 blocks that way, but I'm also currently the president-elect of the College of American Pathologists, and I'm here representing the CAP. So I wanted to agree with Susan and Scott's statement earlier about there was a bit of a gap in the early part of the COVID pandemic. We had public health laboratories and large commercial laboratories that were sort of in the communication loop, but the rank and file clinical laboratories maybe were not quite in that loop at first, and we felt that was a real gap. And I would like to suggest that, an organization like the CAP, most clinical laboratory directors in the country are members of our organization. We accredit over 8,000 laboratories on behalf of CMS and CLIA through deemed status. We provide proficiency testing materials for over 20,000 laboratories worldwide. So we are connected with the rank and file clinical laboratories. So I would just suggest that, perhaps if we had been involved a little earlier, and for the future, we would want to be involved in that communication chain to make sure that that gap doesn't exist.
I couldn't agree more. And all of our members are CAP accredited, so thank you for your work. But absolutely couldn't agree more that that's why we get back to that idea, right? Have that permanent, durable, public-private entity, call it a board, call it a forum, whatever it is, we need that to be established, and all the key players in the ecosystem need to be at the table, because you can't do the job you want to fully if you don't have the information.
Yeah, so we would love to, play that part going forward. And then a brief comment about interoperability. So I think maybe that's a two-part phrase, the way that's being used today. One strikes me as clinical data interoperability. And I'm very happy to say there is a SHIELD initiative. Many in the room probably know about this. It's sponsored by FDA and ONC. The CAP is part of the SHIELD community. We have high hopes that good things will come from that. It's gotten off to a bit of a slow start, but I think it's picking up steam. And so I think there is some hope there for the future. The other way that maybe interoperability was intended is how we communicate with public health laboratories. And it is, maybe that was not intended, but I sort of heard that in that question. And it is difficult for clinical laboratories to communicate with public health labs. I'm sure, Scott, you're very familiar with this, because every state and jurisdiction has different requirements. And so we would very strongly encourage maybe a federally mandated set of key data that all laboratories would know to report to their public health laboratories.
So I think that's a great place to end. I apologize, it is noon, but it's a great place to be in the National Academies. As a member, I'm very proud of the fact that these reports are actually read by the federal agencies, by the White House, by the Domestic Policy Council. So I think a very robust report, Asha, which outlines some of these key elements, really are going to be critical going forward. So thank you all, and we're ending at 12:01.